And our next speaker will be engineer Mohamed Adel. He's working in Egypt. He's with the Medtronic team in Egypt. He will talk about how to support the Micra, the leadless pacemaker implant.
Hello. Now we will talk about how to support Micra leadless pacemaker implant in brief. First thing, the difference between the transvenous pacemaker still and leadless pacemaker. Transvenous pacemaker still encounter challenges, including pocket and lead related complications. And the leadless pacemaker removes the pocket and lead, which account for 2 or 3 of transvenous pacemaker complications. We have 2 types of leadless pacemaker, Micra VR and Micra AV. Micra VR work like VVI device, the traditional device, and it's 93% smaller than conventional pacemaker and 63 fewer major complications than traditional pacemaker. And more than 4,000 Micra VR patients studied in global clinical trials. Micra AV have an accelerometer-based mechanical atrial sense with one bullet or one device based on right ventricle only. It allows us to sense the patient movement and increase the rate and tracking the atrial contraction and to right ventricle. Median AV synchrony at rest in complete AV block patient with normal sinus rhythm 94.3%. Reduction in complication. Leadless pacemaker provides the potential to reduce pacemakers complications rate in the association healthcare utilization cost and reduction in infection. Leadless pacemaker provides the potential to avoid the healthcare utilization costs related to infections. Improved patient access. 24% of patients with a Micra VR implant had a condition that the implanting physician felt precluded them from receiving a transvenous device. This is the difference between Micra AV and Micra VR. The main factor between, the main difference between Micra AV and Micra VR is the pacing mode. Micra AV have a VVI and VVIR or VOO, OVO, VDD, and this is a special mode in Micra AV with one bullet or one device in right ventricle. It senses the mechanical contraction in atrial activity. Micra VR can switch to VVI or VVIR or VOO or OVO, or we can make the Micra leadless pacemaker of that we didn't find in transvenous pacemaker. It has the same mass and the same volume and electrode spacing, and everything is the same like Micra VR and Micra AV. The only thing and the only feature added to Micra AV is mode VDD and VDI. Implant procedure. First thing, access and navigate. This is a Micra introducer. We have a lubricant hydrophilic coated with 23 French inner diameter and 27 French outer diameter with silicone oil coated dilator tip. The 23 French Micra introducer replication hydrophilic coating facilitates smooth entry into the vessel. And this is a video to how to access the right ventricle. Now the introducer on the tricuspid valve, and after that he go to septum before he deploy the Micra bullet. After that we deploy the device. Linear one-step deployment ensure controlled capsule placement, no torque requirement. Femoral approach and flexible distal caster design result in an 11% push efficiency. This video on a fluoro after deploy the bullet on the right ventricle. After we remove or deploy the bullet to right ventricle, you still have an access to reposition the bullet because there is a time between the guiding system and the bullet or the leadless pacemaker. If we test this at this position and we don't have a good threshold, we can reposition the Micra and get the maximum threshold or the perfect threshold. This is the animation of how to deploy the Micra in one shot. Forward pressure to engage the myocardium. Caster retract allow the tinies to touch the myocardium and engage to myocardium and get best threshold. After we position the Micra at right ventricle, we have to test or if we need to reposition the bullet. This video, firstly, we have to make sure that two tines have engaged to the myocardium. We have 4 tines. If 2 tines in one fluoro view is okay, that means its tine have 15 times to the holding force necessary to hold the device in place. But we have to make sure with 2 view. This video with view, we test the stability of Micra, and we have 2 tines engaged to the myocardium. And this animation, like, we don't have to pull back with strong power, only to pull back to make sure that the 2 tines is okay and engaged to myocardium. This video viewing the reposition of bullet after we engaged to septum and didn't get a good threshold. You can engage to apex before you cut the tines or the tether. Before you cut the tether. After that, Micra transcaster pacing system can be turned off, and additionally Micra device can be added. A Micra device takes up 1% of the volume of normal right ventricle. Micra transcaster pacing system can be turned off, and a traditional system or upgrade can be implanted. The Micra design incorporates a proximal retrieval feature to enable accurate retrieval. This video how to extract a Micra from right ventricle or from apex. A clinical trial experience 725 patients. 2 patients experienced increased threshold and 1 patient required a CRT upgrade. In all cases, it was possible to successfully either turn Micra VR off or retrieve the device. 1 Micra VR device was retrieved 17 days post-implant and replaced. 2 devices were turned off and successfully replacement with transvenous system. Micra designed as the world's smallest pacemaker can be left in the place at the end of service because of its size. So we can add other Micra behind the old one. Consideration for leaving in place: electrical interference. Device programmed off will not interface with subsequent device at end of service. The presence of Micra doesn't preclude patient from receiving upgrades in the feature MRI safe, still safe for 2 device. That means if we implant 2 device Micra, the patient can make MRI procedure correctly. While Micra provide effective therapy, patient can preserve their vascular and eliminate all worries associated with lead and pocket-related complications. Small form factor reduce the necessity of retrieval or extraction at the end service. Micra device take up 1% of the volume in the right ventricle, and the average heart can accommodate 3 Micra device. That's it. Thank you.
Thank you, Mohamed, for the presentation. And if anyone have any question, yeah, please.
Yes, thank you very much for the presentation. The longevity of the Micra is how many years first, and the risk of perforation?
With Micra, no risk of perforation, or a minimum risk of perforation, because we don't have an active fixation lead. That it's just a 4 tinus. When we deploy the device to myocardium, it's only take 1 milli or 2 milli from the myocardium, and we have to make sure that 2 tinus only is engaged to the myocardium, no 4 tinus, and that means no risk of perforation with Micra.
There is a minimal risk of perforation with Micra. I was in the course, and there are some predisposing factors for this risk, which is age of the patient, dilated heart, dilated thin right ventricle, implantation in the apex.
Typical position.
Yeah, implantation in the apex, and of course if you don't know how far you engage, yes, but yes, there is a risk, but very low risk of perforation. Your second question was about the longevity. Yes, they have improved the longevity of Micra from 11 years to 15 years. Oh. And that's good, because sometimes you have patients 50 years and they have infection on the right and the left, and you are thinking of a solution, and the solution is the Micra. The Micra is the solution to have a pacemaker implanted inside the ventricle without wires, without the connection, without pockets. The most important dangerous part of implanting a pacemaker is infection. Infection could end the life of the patient if you cannot do extraction, or if you do extraction and you perforate the heart.
Yes, and really we need it in our setting, because usually we are having so many cases with infections, but the price, probably we can arrange some particular prices for our patients. How do you see it?
The problem is the technology is not thinking of us. And I was in Madrid, and I raised a big question. You are talking about pulsed field, 3D mapping, HD grid, intracardiac echo. This is for you, not for us, but this is unfair. If we can have a company like Microport manufacturing a competing device, then the price will be very low and can be affordable. Why my life is not being saved by this because I don't have money? Shame.
That's true.
Shame for humanity. Thank you, Adel, very much.
I have
we have a question from Dr. Mohamed Saeed is an intelligent star of Egypt in the field of electrophysiology. He's running in the National Heart Institute, and we are really blessed that he is one of my team. Dr. Saeed.
So in the future, you will have a retriever system for the Micra. For how long after the implantation you will not be able to retrieve because the Micra because of fibrosis?
I will answer your question because this is what I learned in the course. They could retrieve Micra after 6 years. Yeah. And when they made studies in animals with Micra, and there is a tissue like encapsulation around the body of the Micra inside the heart. And this gets longer and longer, and some reactions of patients are unexpected. So you don't know, this patient makes a very huge capsule around the body, this Micra device. The retrieval, there are some tips and tricks in the retrieval of Micra. What they showed us, Alfie was with me, they use a snare. There is special snare which can go inside the sheath and the retrieval system. The retrieval system of Micra is the delivery system. If you are going to push a small, like a small snare which can hook in the end of the Micra. But another technique which looks to us easier
is you can retrieve the device using the delivery system with a very small loop snare, or you can use the regular Agilis cheese, which is introduced inside the 27 French sheaths of the Medtronic of the Micra, and you can use the regular snare, whatever it's a 3-loop snare or the other circular snare. So you have two techniques, or the published now are two techniques. One using the delivery system of the Micra with a small snare in order to be able to grab the Micra and go inside the delivery system. And the other one is using a regular snare with a Agilis sheath inside the sheath of the implantation of Micra.
Okay, there have been any infection of vegetation over the Micra?
There was recorded cases of vegetation on the Micra, but very, very, very minimal cases, and they have to retrieve it. So, rare.
I have a question. So I'm assuming when you are...
Please introduce yourself, Willie.
Yeah, so when you're retrieving the Micra, I assume you're using a fluoroscopy. And you said it occupies 1% of the volume of the right ventricle. So I'm imagining the technicalities of, locating the device and, the part where you put the snare, like how do you do it practically?
Yeah, actually, retrieving the Micra is not easy, because you have to be aligned with, even if you are, I have seen that retrieving the Micra with the delivery system is much more harder. I didn't try retrieving the Micra, but the cases which were published, that retrieving the Micra with the delivery system, you have to be aligned with the delivery system on the Micra, but with the help of the snare. So you have to snare, you have to push the delivery system very near to the Micra, and then try to snare it from the bullet side, from the end of the Micra with the snare, and you have to align the delivery system in order to try to pull the Micra inside the delivery system. It is not a piece of cake, but a lot of doctors did it. So it is published, and it can be done. Using the regular snare, which is much more bigger than the smaller snare, it will be easier for you that you can catch the Micra from the body. You can catch the Micra from the middle of its body, and sometimes there is a published case which was dislodgement of the Micra in the pulmonary artery.
And they could retrieve it.
They could retrieve it also from the pulmonary artery using the snare, and they grabbed the tines of the Micra. So there are some published cases that you can see on the internet that they would successfully retrieve the Micra, even which is when it is in the pulmonary artery.
I have quite a number of questions. Is the deployment by passive fixation? If so, is there any risk of dislodgement? And do you do the normal programming like any other pacemaker? And can it be used as in place of CRT, or is it purely for bradycardia treatment only?
Adel?
Could you repeat the question?
I will answer your question.
Passive or?
This is not passive fixation. This is active fixation tines, and there are 4 tines hooking coming out from the bullet. So when you deliver the Micra, and before you cut the thread which connects it to outside, you have to make a tuck test, which is you pull the thread and you look how the Micra would look on fluoroscopy. You have to be in a good fluoroscopy view, and also you have to have magnification. Adel in his presentation showed us the 4 tines. So when you make this tuck test, you look, are these tines coming up and down, opening, closing? This means that they are anchored to the trabeculae of the right ventricle, and they are moving with your pulling. You don't pull much so that you don't dislodge, but it needs some sense of pulling. Then after that, you cut the thread and you take out the delivery system. This is your first question. Your second question is the interference between the Micra and other machines. Micra was implanted in patients who need bradypacing in presence of subcutaneous ICT. So it is no interference. Even with they showed us in this course, with those who have stimulation for Parkinsonism with 2 batteries on the chest, there was no interference. Regarding programming, don't implant Micra without having the software or care link which can program it. So, and also in the cath lab, when you implant it, this care link programmer Medtronic is very essential, so that you measure the threshold, the R wave sensitivity, the impedance, and you wait for more measurements. This is how a Micra should be implanted. This is why Medtronic will not give you Micra. Will say, okay, I have a patient needs Micra. No. We have to have a proctor who has a certification that he knows how to implant Micra, in order that you buy Micra. Whatever money you have, they will not give it to you. So yes, and there is a procedure in Medtronic for training. You learn 3 modules online, you get your certification, then you go to a training course, and then you get a proctor, and then you are on your own. This is what Medtronic does, and this
about the bi-V pacing and if it is.
There is some invention of CRT, wireless, and this Micra, but these are all still investigational.
Don't have it in the market. Yeah.
Investigational. Very nice question, Josephine. Dr. Ashley Shin from South Africa.
Just a comment. We've been putting it in since 2016, and so we've got some experience with Micra. I mean, the main issue for us is the cost. I mean, it's in South Africa it's 10 times the cost of a single chamber pacemaker, and so we've really needed to use it in very niche roles like recurrent infection and vascular access issues. And so I'm not sure what other people's comments are about the indications for the Micra beyond those sort of niche indications, and especially in the setting of conduction system pacing, pacing the right ventricle myocardium long term, that does sort of come into the equation now. So I just want to hear what other people think about the indications for this, or the role for the Micra.
There are some restrictions in Egypt in order to get the governmental approval for Micra. They support it, but very, very, very limited situation, that the patient should have infection, both sides, or documentation, and some high-class doctors will give the signature.
And Ashley, in South Africa, what was the main indication? Was it always the lack of venous access?
Yeah, I mean, the first 5 we put in we were part of the original study, the Micra study. So we, the first 5 devices, we were part of a study and we managed to put it in. But then after that, we really had to, because of the cost, we had to limit it to recurrent infections. We had some patients with vascular access issues. And those were the main indications why we went with that. Yeah. And sorry, renal dialysis sometimes, patients who are going to have recurrent risks of infection, we put them in as well.
Mahmoud Adel.
My question actually is partly answered, but
Can we know who you are?
my name is Abi. I'm a cardiologist here in Rwanda. And partly answered, but how common is spontaneous dislodgement and embolization? How common is it?
Uncommon. As Adel have said in his presentation, we have 4 tines, and the presence of 2 that are well anchored gives a force of 15 times more than needed because of its small size and weight. So only 2 from the 4, if they are well anchored, this gives a confidence 15 times more than needed. So it's very, very rare.
Okay, we move to the next speaker, Engineer Mahmoud Adel from Boston. He is going to talk to us about pulse field ablation.
So, hello everyone, good afternoon. First of all, I'd like to thank Dr. Mervyn, our esteemed president of AFRA, for giving me the opportunity today to be among of this distinguished group of professionals. So first, I just need to introduce myself. I'm Mahmoud Adel. I'm based in Egypt, and I'm the product manager for rhythm management for North Africa region. So, as we know, the atrial fibrillation world has been dominated largely by 2 primary